next one. Hi, everyone. My name is Pauline Ray. I'm the program manager for Seattle Children's Team B, or Telemedicine Extension for Adolescent and Child Mental Health Borders program. We are a new pilot program at Seattle Children's. I'm joined today by Dr. Brooke Rosen, my counterpart. And I am just going to give you guys a high-level overview of our program. So Team B is a pilot program that will provide telebehavioral health consultation to emergency departments across the state of Washington, primarily to care for youth who are boarding in emergency departments. Next slide, please. So the primary aims of our program are to improve the timeliness of mental health care and reduce the length of stay for youth boarding and community EDs, and to support the ED staff in providing more developmentally appropriate and evidence-informed mental health care for youth while boarding. And then another challenge, as many of you know, across our region here in Seattle, is that we at Seattle Children's are one of the few providers of pediatric mental health care services in our region, which results in us getting a lot of transfers to our own ED from community EDs. And so we are also hoping that our program will help decrease our own volumes in our ED if we can meet our patients and families where they are in their own communities and provide the service to them in their communities. Next slide, please. So we currently have two sources of funding. We're funded by the University of Washington Garvey Institute for Brain Health, and we have funding through HRSA. We started as a one-year pilot program and recently received extension funding for the next 3 years, which we're super excited about, as we hope it will help us more fully realize our vision for the program. Our biggest funding challenge so far is just realizing the many layers that have been needed to launch our program. Brooke will talk more about those barriers later. And overall, one of the major goals of our project, aside from the clinical aims, is to use this pilot to advocate for additional and potentially statewide funding for more ED telepsychiatry support. Next slide, please. So this sort of describes, our project to date. This slide makes it look like the steps are linear, but really it's been more of an iterative process for us. We began by doing a literature review of a lot of similar programs across other regions and talking to other people across the United States who have similar programs, some of whom presented today. And once we obtained our funding, we launched full speed into the many facets of our program. We finalized our team, which we'll discuss more shortly, and we began to operationalize our ideas. So we have developed manuals, screening tools, workflows. We've also worked with our IT department on administrative tasks like just setting up dedicated phone lines and emails and figuring out how we'll receive incoming consults from other hospitals. We've worked as a team to discuss how consult requests will be triaged and how the information will be disseminated to the providers so they can actually do the consults, as well as working on tools to store and collect our de-identified data for later analysis and use. We have also been doing a lot of meetings with our legal team, our internal review board, principal stakeholders, our state of practice committees, to ensure that we're meeting all of our institutions, the state and the federal requirements ahead of our program implementation. And finally, we've also been working on hospital outreach. Chona and Trevor have been party to conversations about that with our flyer and listservs, and we conducted recently a statewide mental health and needs assessment, which Brooke will talk about more later. And we distributed our needs assessment in the early fall and have some results to share for you, so we're super excited about that. And finally, we are hoping, we are very close to launching and implementing our program and going live. So we have sort of one final step to go. So we're hoping that will happen soon, and then we'll be able to share more information in the future. Next slide, please. So this is our team. Like I mentioned before, I'm the program manager. I'm also a licensed independent clinical social worker in the state of Washington, mental health therapist. So my role is to provide the triage consultations, program administrative support, provider and family education, and community resources. I'm working also with a BCBA who will provide behavioral health support, provider and family education, and also community resources specific to the IDD and ASD population. And then I have 3 psychiatrists on the team with me. Brooke Rosen is one of them, and 2 more as well. So we actually have a robust team with multiple disciplines. So we're hoping to provide comprehensive services to the providers that we consult with. Next slide, please. So this is our team. Well, I think we're behind the slide. You can go to the next one. There you go. That's our team. So there's me and Dr. Brooke Rosen, Carol Rockhill, Dan Crawford, and Andy Song-Sherbel is our BCBA. And I'm going to go ahead and turn it over to Brooke so she can give you more detail about our background, the model, our barriers that we've experienced, and our mental health needs assessment.
Thanks, Pauline, and thanks everyone else for hanging in there to this point in the day. So I'm going to talk more about the background that informed the development of our project and also a little bit more about the actual model itself. So we're all very well aware of the scope of the problem and the need for effective interventions in children's mental health. And for those of you who have been on the webinar all day, we've heard some really fantastic work going on in places around the country, really innovative models and ways to even keep kids from getting to the stage of needing emergency department care. And so this project is just one small sort of piece of that puzzle. And we know that really it's going to be critical to do those other interventions in parallel to keep kids from getting to the ED in the first place. But while they're there, our hope is that we can help improve the experience. So there's not a lot out there on pediatric specific, in general pediatrics and pediatric mental health and EDs specifically, since it is a relatively newer phenomenon. But we know that on the adult side, providing specialty mental health services in emergency departments can reduce length of stay and can improve care for adults who are boarding. We do know that for kids who are boarding, that is also true. What we don't have a lot of information around is whether those services can be provided or improved by telepsychiatry services. And so on the adult side, again, we know that telepsychiatry consultation can be effective at reducing stays, reducing unnecessary hospitalizations, lowering the overall cost both to hospitals and to patients, and then also helping with outpatient care transitions. But we just don't know a lot in pediatric ED telepsychiatry specifically because there haven't been that many models out there. So our project is really, we wanted to understand better what existed before we created something from scratch. So in order to do that, since there wasn't a lot to draw from the literature, we talked with folks around the country who are doing similar projects or sort of parallel work. And so we spoke with folks internally, and I'll describe these acronyms. So PAL is Washington State's version of our Child Psych Access Program. So consultation to primary care providers or pediatricians with psychiatrists and specialists around questions related to mental health. And so we spoke with folks at PAL, we spoke with folks at PCL, which is the adult version in Washington of PAL, so similar primary care consultation, and then also with staff and providers within our own emergency department. And then on a national level, we were able to connect with teams doing sort of similar or parallel work in different places. So Colorado Children's, NC STEP, Northwell, different project, but similar institution from the speaker who was on just a couple of talks ago, and then Intermountain Health in Utah. And so we learned a lot from these conversations. It was really helpful. But we also learned that not a lot of people or teams had programs in place that were similar to what we were trying to do. So the main difference is that these programs did have emergency department telepsychiatry or telemental health consultation, but they all were, with the exception of North Carolina, were all within the same hospital network, just across the state. And so that made it a little bit different than what we're trying to do, actually a lot different, in that they were all working within the same healthcare system. And so they didn't have to think about things like medical records, billing, finances, contracts, documentation, things like that, that when you're working across hospital systems become very complicated. And so I think that that's a big difference in terms of the work that we're trying to do. And so the model that we came up with and that we are hoping to launch soon is really a consultation model. So there's a few different types of consultation models, and some of them, so the folks that I had on the previous slide, a lot of them were doing direct evaluations through telehealth for kids who were in outside EDs, sort of like a hub and spoke model. For us, since we aren't, since the scope of our project is more limited in consultation, and we're really envisioning it more as sort of the ED equivalent or acute care equivalent of a PAL model or the access program model, it's really going to be strictly provider to provider consultation. So we're not going to be seeing kids and doing evaluations, even though we know that hospitals would love it if we could do that. But it's really more designed to be sort of an advice and consultation line. And so the basic model is that we have done outreach to hospitals, we'll continue to do that. And then as they get kids in their ED and they don't have the mental health staff or pediatric specialized staff to care for them, they can call us. We'll have an intake, a sort of standardized intake, and then triage to the appropriate team member. Sometimes that might be one person, sometimes it might be all three. And then we'll do like a sort of a verbal recommendation outline, and then also document some of our recommendations and send it to them. We won't be using the medical record because we're not assuming care, but that's kind of the model that is similar to what PAL and the adult version of PAL does. So we're really envisioning this more as a QI initiative and model of care that we're exploring rather than strictly clinical research. And so most of the data that we're collecting is more qualitative and understanding, what's useful about this project, what's not working, what are barriers, how is it being perceived, how can we be more helpful? So as Pauline mentioned, one of the things that we have been able to do without officially launching the program yet is to distribute a mental health needs assessment to hospitals across the state of Washington. So this is modeled, there was a similar effort in Vermont, and I can include the link later if people are interested, to do really like a statewide look at what's really needed for kids in emergency departments presenting with mental health concerns. And so we really just are trying to collect as much information as we can about what the need is and how we can be helpful. So far we have 37 respondents, and I believe it's out of a total of around a little over 100 hospitals in Washington. So still hoping to get some more responses in there and have some outreach planned. So far, most of the responses have been Western Washington, Puget Sound area, but we have gotten some more rural hospitals in Eastern Washington responses as well. Most of the folks responding so far are actually not medical providers, which we would like to increase that number, since those are the folks, the providers and social workers and RNs who are really on the ground doing the care. But most of the responses so far have been more, I would say, administrative level, like ED managers and things like that. So far, one of the questions that we were interested in is like, where are these kids boarding? For us, it's in our emergency department, but for other systems, it might be on the medical floor, pediatrics floor, and so far the majority of kids that we've gotten responses on are in the ED itself and not on the medical floor. So on the subject of qualitative data, so we are really interested in understanding the experiences of staff who are working in the ED. And again, this is might be a little bit skewed because they're not, the responses are a lot of non-clinicians. But we thought that this was helpful information. So in general, how comfortable do you feel caring for pediatric mental health patients in your ED? The majority, I would say, not super comfortable, not at all, or somewhat comfortable. And so we're hoping that providing consultation services and doing more types of training and education, sort of similar to an ECHO model, will be helpful in changing that number. And then I think the other thing that we found really striking is the impact that caring for these kids has on overall job satisfaction, with 75% or more really having somewhat of a negative impact. And going back to sort of the Mary Bridge speaker about the concept of moral injury, I'm not sure that this is really, people not having a good experience taking care of kids. I think it's more that the systems are really not set up to support them. And that's what we're hoping to help with. And so then almost done here, the anticipated program utilization. So in the survey we sort of described our model. We said, this is what we're planning on. If this is something available to you, would you use it? And so 97% of people said yes, which is great. That's what we're looking for. 53% of hospitals don't currently have a telepsychiatry program in place. For those that do, often they're contracted with vendors who are out of state, who don't know the local resources as well. And then in terms of frequency, it seems like it would be an anticipated, well-utilized program. So I'll just breeze through this. Basically, this was listed as a multiple choice question, and we said, of these options, which type of services would you find helpful? Basically, all of them. So I think these hospitals without robust mental health staff, or any mental health staff, just really struggle to take care of these kids. And then last, the hopes for Team B. So these are some examples of what folks would want help with. And then I will say, just my last real slide here is implementation barriers have been huge for us, and we're more than happy to talk with anyone else who's doing similar work or similar projects. Would love to hear if people have experience getting through some of these and can also share some of our experiences. And I think really the main barriers for us have been a lot of regulatory and liability concerns. And I think this exists in the access programs to a lesser degree, but in the emergency department setting, it is such a high acuity setting and high risk that there's a lot of legal and liability concerns that come along with that, especially if we're not providing direct evaluation. So we are currently working through those and hoping to be on the other side of that soon. So I will just skip over that. And then here's our information if you'd like to contact us.
Time for maybe one question. That was awesome. Thank you so much for presenting that. It's going to be an amazing resource if you can get through the red tape, and boy, I feel you. All right, hearing no questions, I will let you go, and with our deep appreciation for hanging in there and for presenting, what you're working towards. I think, as I said, I think it's going to be amazing.